tissue implantation from the same human donor. With us today is Dr. Joseph Turek, Chief of Pediatric Heart Surgery at Duke Health and Associate Professor of Surgery and Pediatrics at Duke University School of Medicine. Joining us also is Kaitlyn and Brandon Sinnamon with Easton Sinnamon himself. Of course, Kaitlyn and Brandon are the parents of Easton Sinnamon, who just celebrated his first birthday last month. And what a joyous occasion it must have been. So excited to welcome you all here today. Dr. Turek, we do want to begin with you. I'm going to ask a couple of questions before we open the floor to media questions. Dr. Turek, could you explain the combination procedures that Easton received? Why is his case so historic? And why might this combination help to prevent rejection of the organ?
Thank you, Stephanie. Yes, Easton's historic procedures entailed a heart transplant, which he very much needed due to the fact that he was born with single ventricle heart disease and had a leaky valve that was very problematic. And despite trying to fix his valve, it was clear that he was going to need a heart transplant. Along the way, in listing Easton for heart transplantation, we found out that he had an immune problem in the sense that he wasn't able to produce T cells in order to fight infection, and he was getting recurrent infections while he was in the hospital. So we used that combination, and Duke is a place that actually transplants patients for both heart transplant, but as well as for thymus transplant in the case of congenital athymia. So we had the expertise to do both. We were able to get approval through the FDA to do such, and Easton got the world's first thymus heart transplant. So I think it's probably good to take a step back and talk about what the thymus is, so that those who aren't familiar with the thymus know what it is. But the thymus gland is a gland that sits on top of the heart, and the thymus is really important for, we call it the schoolhouse for your T cells. So all of the cells, the immune fighting cells that come from different parts of the body, they localize to the thymus, and then the thymus helps to grow those cells up, and it tells the cells, this is self, this is not self, and that's how your body knows how to fight. What is an infection it should fight, and what is something it should reject. And so the combination of those two was very intriguing to us because we've done work in the laboratory along these lines. And we thought, if we did a thymus and heart transplant on Easton, there's a potential that taking that from the same donor would allow that transplanted heart to be recognized as self, because now the heart that was transplanted plus Easton himself is growing up in this new milieu where the thymus is recognizing both donor and self as self. So this is a concept known as tolerance, and tolerance has really been the holy grail for transplantation. As such, this could be applied to all solid organs down the road potentially if this works. But what it could mean potentially, the ramifications could be that it's possible that he wouldn't reject his heart even if we took off all of his immunosuppression. So he's currently on some medications that allow his body to prevent him from rejecting, just like all transplant patients are. But we believe that if he's developing tolerance here, we'll be able to withdraw all of his immunosuppression, and he'll still be able to recognize this heart as self.
Thank you so much, Dr. Turek. I have so many questions to set the stage for all of the research that allowed this to happen. But first, I want to check in with Kaitlyn and Brandon Sinnamon to find out what their journey was like leading up to this historic moment. Tell us a little bit about some of the health challenges that Easton faced leading to the transplant and thymus procedure. How did you arrive at your decision to move forward with these procedures?
I think the biggest thing is I was about 20 weeks pregnant with him when we found out about his heart defects. And so we knew he was going to need a heart surgery at the beginning of his life. And with the journey that he had between the first heart surgery, and then he ended up having to get put on ECMO, which is life support. And then the leaky valve that Dr. Turek mentioned that, we tried to repair that and it still leaked. And I think our biggest thing was seeing him continue to fight, and we knew he wanted to be here, brought us to the decision to do transplant. And Dr. Turek took the time to pull me to the side, and we talked and sort of came to the same agreements that we needed to do this to give him the best life possible that he could have.
Absolutely. Well, Dr. Turek, you said that it was serendipitous that Easton was in need of both of these procedures, the heart transplant and the thymus tissue, independently of one another, and that he was a patient here at Duke. Why is it important that these factors aligned? And could you tell us a little bit more about the processed thymus procedure in and of itself, and a little bit about the research that you were doing before Easton presented on the use of processed thymus and solid organ transplant?
Yes, Stephanie, it was serendipitous in the sense that Easton needed both a heart transplant and he also had very poor immune function. We do each of these operations independently here at Duke. We are the only place in the Western Hemisphere that does cultured thymic transplantation for patients with congenital athymia. So we had that expertise in-house to be able to do this. We also perform many heart transplants at this institution and have an expertise in that field too. So the fact that he needed independently a heart transplant and a thymic transplant really allowed us to be able to have discussions with the FDA and to gain approval to try this really groundbreaking work in his situation with little less risk than we would have otherwise. In the laboratory, we've been looking at this, so of a number of groups for decades, at how you can use the thymus tissue in order to develop the tolerance that I was speaking of. The main issue that we have is we're trying to figure out how we can do this in a patient who has a very competent immune system, in which you're going to have their own immune system competing against this new thymus immune system from the donor. And so that's really been the major obstacle in the research. And we feel like we're making progress with this in using this cultured thymus tissue, because truly the way we do it with the cultured thymus tissue, that allows a scaffolding to be created. And so you don't have all of the other cells within the thymus. Rather, you just have a scaffold in which you can form a brand new immune system. That schoolhouse that I was talking about can start from scratch. And so this new organ, whether it be a heart or a liver or a kidney, can grow up with that new thymus together and be recognized as self. So I think it's one of the major pieces is the fact that this culturing process is vitally important for this to be able to work. And in Easton's case, it was really important that he did not have a competent immune system. Once this is translated to patients with competent immune systems, I mean, this could affect thousands and thousands of patients in transplant down the road.
Dr. Turek, I do want to ask a follow-up question to that. Can you back things up for us a little bit and explain to us, you mentioned tolerance is the thing you really want to achieve with transplantation. Can you tell us why, and a little bit about the longevity of an organ transplant, what you're hoping to investigate and learn through Easton's case?
Yeah, those are great points, Stephanie. So, currently, if you were to get a heart transplant or really any solid organ transplant at this point, you would be on a good amount of immunosuppressive medications, and those are just to prevent you from rejecting the organ that you've received. These can be quite toxic. They can be quite toxic in the sense that they can cause kidney dysfunction. They can cause recurrent infections. You can even end up with different types of cancer from being on these medications for long periods of time. And so the idea that you wouldn't have to be on immunosuppression is the real benefit of this idea of tolerance. So if you are recognizing the organ as self, you no longer have to be on these really toxic medications, and that really changes the game for someone who gets a transplant.
Excellent. And I do want to get to a couple of the media questions in just a little bit. I want to remind everyone on this call that if you use the Q&A function or the chat to send in your questions, we're happy to ask those. But I want to get to Kaitlyn and Brandon with the next one. Both of you mentioned, Easton being on life support. I know that you all live a ways away. He was in the hospital for 7 months. I'm sure that it has been a really long and taxing journey. So can you tell us a little bit about what it was like for your family to experience all of that with a newborn child for all that time?
It was a lot. We have a 4-year-old daughter. Whenever all this was going on, we had to find somewhere for her to be. We were away from her for long periods of time, but we stayed in Airbnbs and hotels close to the hospital, especially whenever all of his stuff was going on. But beyond that, the long stay on the transplant list, it was a lot of trips back and forth. Kaitlyn made the trips 5 days a week while I was at work, and we both come on the weekends. And it's about an hour. It's about an hour from the house. But yes, it's been a pretty long journey.
And how did you all get through that? I mean, I'm sure there must have been moments where you were looking at tough days, tough decisions. How did you make those decisions? Why did you make the decisions that you made? And how did you find the strength to make those decisions?
I think the biggest one is we have a really good support system with both sides of our family. So we were able to discuss things with them and sort of come to, figure out where we agree on things. They were a big help with our daughter. They watched her for the first 2 months that we were living in Durham. And so she got a lot of grandparents' time. But I think us just relying on each other and talking everything through and coming to the best decision possible for him is how we did that.
Thank you so much. Well, Dr. Turek, I want to ask you, how is Easton's immune response doing? Why will his progress be significant to watch? And what is it that you're watching for?
Yeah, I'm happy to report his immune system is responding very well to the transplant. This transplantation was done. This transplant was done in the summer, and we've actually waited to announce this because we wanted to make sure that Easton's immune system was responding. And sure enough, he is developing his own immune fighting cells, these T cells, and we're very excited about it. We'll continue to follow his T cells and make sure that they're sufficient. And at some point, we're going to start weaning back off of his immunosuppression, and hopefully we get to a point where he doesn't have to take any of that medication in the future.
Thank you so much. And I want to get to some of the questions that were submitted ahead of the briefing. We have one from the Associated Press. Has this been done with transplants of other organs other than the heart? Has it been done? Has this ever been done before?
Yeah, so, as far as to my knowledge, it has. And I think the particular thing about this is we're using cultured thymus tissue and implanting that. And I had touched upon this earlier. We're not just using fresh thymus from the donor, we're using the cultured thymus tissue. And I think that's a very important piece to this, so that you don't get rejection. But yeah, this is the first, to my knowledge, of any organ transplanted with cultured thymus tissue.
Thank you so much, Dr. Turek. And also, folks want to know, are there any obstacles that may stand in the way of future procedures? Would this work only in tandem with a heart transplant? And can you talk about how this would work in a person with a functioning immune system? Would there be a different outcome potentially?
Well, the functioning immune system is where more research needs to be done, and we're working on that in our laboratory, trying to figure out how we can effectively do transplantation in someone with a competent immune system and competent thymus. Clearly, when we did this transplant on Easton, we did do a complete thymectomy just in case he had some T cell function, and that would be part of the procedure going forward for patients that would be able to benefit from this co-transplantation type of technique. Because the thymus lies within the chest and specifically over the top of the heart and the aorta, it seemed like the most logical way to research this was by looking at thymus heart transplantation. And that's why we have this is what we've studied in the lab is cultured thymus heart transplantation. So if you were to apply this to other organs, which it could be applied to other organs, you would have to figure out a way to do a thymectomy to take the thymus out of these recipients prior to them getting their transplant.
And Dr. Turek, does Easton have congenital athymia? Can you just take us through his diagnoses and what we know about his case before the procedures were performed?
Yeah, he doesn't have congenital athymia. You know, he passed all of his newborn screening, and so he was not thought to have at the time any immune dysfunction. Initially, when we met Easton, it was just because he had single ventricle heart disease, and we performed a few heart surgeries on Easton, and then that's when we had to list him for transplant because of some issues with his valve leaking. And that's really when we found out that he had some immune dysfunction. He was having recurrent infections. It was keeping us from continuing to list him on the heart transplant list because he kept getting subsequent infections. And so that's what triggered the workup. And it looks like he has a T cell deficiency. So these immune fighting cells, a deficiency of those immune cells of an unknown cause.
And Dr. Turek, can you discuss how Easton's age played a role in any decision making throughout?
Yes. So when we do transplantation for congenital athymia here at Duke, it's only approved for patients that are under the age of 9 months. And so I think it helped us as far as being able to get FDA approval to do a thymic transplant on Easton, because he was at the time, I believe Kaitlyn was 5 months, 6 months old when he finally got his heart.
I think he was around 6 months old when
6 months old. Yeah. But you know, we're in the laboratory, we're looking at what is the age of a thymus that could potentially act as a transplantable, you know, a potent enough thymus to be able to do transplantation on. So it's part of the studies that we're looking at, just so that this can expand the number of patients who could benefit from this procedure, and not just be infants, but could potentially be, you know, 10, 20, 30-year-old donors.
And Dr. Turek, I wanted to ask you, speaking of age, you know, when we're looking at building that tolerance and you're looking at potentially expanding the viability of a transplanted organ many years, how significant is that for a pediatric patient specifically?
Right. It's very important. You know, usually when we do a heart transplantation, we kind of think in our mind that, you know, the clock kind of starts ticking. You know, heart transplants in this day and age last about 10 to 15 years. We do a lot of heart surgery on kids that are very palliative, just to get them as far along as we can before we need to do a transplant. And the whole idea for that is because the organs don't last forever. And like I said, it's about 10 to 15 years right now for a heart. It's different for other organs in the body. But the idea that if you could develop tolerance and you didn't have all these episodes of rejection, which are, you know, these constant episodes of rejection are what eventually leads to the graft, the heart, failing. And so the idea is, if you don't have all these episodes of rejection, potentially this transplant could last decades.
Thank you so much. And Kaitlyn and Brandon, correct me if I'm wrong, but you all, I believe, had Easton at Duke. Is that correct?
Yes, we did.
And so what impacted your decision to come to Duke? Did you know that you would need this amount of care for him when he was born? Why did you come to Duke? And then what was the experience like as soon as the birth started and before the birth even, really?
So we knew that Duke did a lot of heart surgeries for newborns and infants. And we actually have a friend who reached out to us who has a daughter that has had surgeries done at Duke that was also born with CHD. And so we knew that that's where we needed to be. And I started getting prenatal care from Duke as well, just so everything could be done under one place. And I think the hardest thing for us was being prepared for him to be born, because we didn't know when he'd be able to come home. And this is with the plan to him having the first heart surgery, you know, done at 5 days old, the next one around 3 months old, and another one around 3 years. So in our minds, that was the plan that we came up with. And so we had made sure we had everything, but you can't really plan for everything that was going to happen.
And then Kaitlyn and Brandon, could you please clarify what it was like for you to travel back and forth from home to Duke? I believe you all live in the near the Asheboro community. Is that correct? Can you just describe for those 7 months what that experience was like and how you traded things off and handled things at home?
Yes. So when Easton was first born, we knew that we were going to spend roughly a month in the hospital during recovery. And so our family got us an Airbnb for the first month and that we stayed in. And then when we realized that we were going to be there a little bit longer, we got another Airbnb for about another month. So we were there from February until April, and we came home Easter weekend, and I started driving to Duke every single day. I would drop our daughter off at daycare, go to Duke for the day, and then come home, pick her up, and go home and do our normal things, cook dinner, you know, do all the household things. While Brandon was working, I knew I wasn't going to be able to work during all of this, so I actually ended up quitting my job before I went and had Easton.
Oh my goodness, I can only imagine from all sorts of angles of life how difficult that time must have been for you all. Absolutely. Well, Dr. Turek, I want to talk about Easton's future. You know, looking at this, can you tell us a little bit more about the long-term benefits of this procedure, if it's successful in the long term, what that looks like? And can you tell us a little bit about whether or not Easton may need to be on any medication to suppress either what would be any reaction from his natural immune system? Is he going to have to be on any sort of immunosuppressants, or will that not be necessary? And how do you know what do future procedures look like for him if he'll need any at all?
Well, after you get a heart transplant, the journey doesn't end there. You know, we surveil the heart frequently with biopsies to make sure that we're not getting rejection, and clearly you're on many medications to suppress the immune system. You know, my hope for Easton is that he truly does develop tolerance here, and I think he has a good chance of developing tolerance based upon what his T cells are doing right now. And I would hope that we could peel off immunosuppression here over the course of the next year, and hopefully he's not on anything for the long term, and then hopefully this also means that his heart transplant could last 30, 40, 50 years. I mean, that would be my hope for him, and I think these are all things that are very possible if he truly shows that he's tolerant to this transplant, which I think he's got a good chance of.
And Dr. Turek, could you clear something up for me? So I know that Easton received his heart transplant, and then some weeks later he received his thymus transplant. Does it have to be done in that manner, or can the two be done on the same day? Can you tell me a little bit about the process behind that?
Yeah, this goes to the idea that the implantation is of cultured thymus tissue, and when we procured the donor heart and thymus and brought it back to Durham, we did the heart transplant, but then the cultured tissue was sent to be cultured, and that the thymus tissue, and that takes about 2 weeks, week and a half to 2 weeks for the culturing process. So this was fine though, because this was, he was still kind of recovering from his heart transplant. And then by the time we had cultured tissue ready for Easton, we were then able to go and under a separate procedure, do the cultured thymic tissue implantation. And then we've continued to be on the same immunosuppression that anyone who would receive a heart transplant would be on. And that thymus that we've implanted has engrafted, and it's functioning properly despite those medications. So that's a big obstacle to get past, for that thymus to be working the way it is, despite being on these different medications that were keeping his heart from rejecting while that thymus was growing up and doing its job. So now I think the next step is to start to slowly test this out and pulling some of his immunosuppression off. There's also some studies we can do too, things such as chimerism assays and MLRs to also look and see if he's truly developed this kind of a tolerant immune system.
Thank you so much, Dr. Turek. Kaitlyn and Brandon, what an important moment in your lives when you finally got to take Easton home from the hospital for the first time after 7 months, the long back and forth, the trying times. What was that homecoming moment like? Tell us a little bit about Easton's personality. Look at him there, nodding his head. What a cutie. How's your life changed now that your family is all back together again? Tell me about the joy.
It's amazing. It's awesome. Something that we never thought was going to happen. Just being honest, the way that he was in the hospital, it was an amazing feeling bringing him home. The look on my daughter's face, she was old enough to understand that, her brother was in the hospital, but she didn't understand why. And it was really hard to explain why. And just the look on her face, bringing her brother home and spending time, and it was amazing. Grandparents, there was a lot of people that, seen a lot of FaceTime video, a lot of picture, but never got to meet him in person. So everybody getting to meet him was amazing. That's about the only way I can put it.
Yeah, there were some tough times there in the hospital.
There were.
Yeah.
There were.
And you all had some surprise reveals, and oh my goodness, I can only imagine what it must have been like to hear, oh, you have a new baby brother, and then to finally see your new baby brother. That must have been so nice for your 4-year-old daughter. Love that.
She was very excited.
Oh yeah.
So cute. Love that happy reunion. Dr. Turek, I have a couple of questions for you. So the Easton's procedures, they happened under an application to the FDA to have this done. At this point, can you walk us through where was the processed thymus tissue? Was that already something that was approved? Why did you need this emergency sort of application? Do you plan on doing any additional organ transplants like this with processed thymus in the future? Does it make sense to do this in kids? Can you walk us through the mechanics of how this all went down?
Yeah, the thymus was in the process of being, the biological license application was in the process of being approved and for a company by the name of 𝐷𝐴𝐴𝐷, and we worked with them on getting this FDA approval, and it went pretty well. I think it was an easy case to make in the sense that we've performed over 100 thymic transplantations here at Duke for patients with congenital athymia, all at the same age group as Easton. And so I think it was a logical choice. And, I do appreciate all the support we got from 𝐷𝐴𝐴𝐷 for getting us through the FDA application process and also, their support throughout this whole thing and their support of the Sinnamon family for this historic transplantation.
Thank you so much. And what comes next, either Dr. Turek or Kaitlyn and Brandon, what comes next for Easton on his personal medical journey? I'm sure he has a couple of appointments still ahead of him. What comes next for him, and how do you gauge the process or progress rather?
I think one thing is we had to make the decision while he was listed for transplant for him to get a tracheostomy, which is basically a breathing tube that's permanently put into his trachea for him to breathe. And he's proven that he no longer needs that. And so we have an appointment coming up soon where hopefully we can get that removed. He does have a feeding tube in place, but he'll probably have that for a while because he'll have to be able to take all his medications by mouth before we can get that one removed. But those, I think, are the biggest ones that we have, along with the heart biopsies that are done every few months just to make sure that there's no rejection.
And Kaitlyn and Brandon, you guys revealed something, pretty significant, I think, when we were speaking at one point, when you were waiting for Easton's heart transplant, when he was on life support, what was that moment like? You said that you talked about Easton being a gift in 2 different ways. Can you unpack that a little bit for me and talk to me about what you meant there?
Kind of the way that we talked about it is, we're heavy believers in God, and we believe that God put him here for a reason, and that we were going to do everything in our power to keep him here. We were going to do everything that we could do, and that's really a lot of prayers. That's how I answer that question. I think it's just really difficult to make decisions when you're being put in a position like that, and I think it all played out for the best.
And I think the other thing is that we not only were able to be given the gift to have our son back, but we were also able to give the gift of this possibility with the thymus to help expand this for other children that are going through the same thing, to make this a possibility for them.
Yeah, and if it wasn't for the amazing team that Duke has, Dr. Turek, all of the surgeons, all of the nurses, everybody there is great. And they really did become a family. A lot of the nurses, a lot of the doctors that we still talk to this day. Every time we go up there for just a follow-up appointment, we make our rounds and talk to everybody and, hey, how you doing? How's it been? And it's a good place to be in a situation like that.
Stephanie, there was a question about that you had asked about whether we're planning to do any more of these thymic transplants. At the current time, we would, if we had another child like Easton who came through and had this opportunity, we would do that. But we really hope that in the not so distant future, this is something we'll be able to offer to many, many more people, and not just babies, as far as patients that have even competent immune systems. So I don't think it's all that far away.
And Dr. Turek, thank you so much for adding that. I wanted to ask you, if there's one thing that you could share about Easton's case and about everything that's happened here, this historic moment, looking forward into the future, if there's one thing that you would like to impress upon the public about this all, what would it be?
Yeah, I think that this is truly, Easton is truly in a landmark situation here, in the sense that this transplant that he had could really change the face of how we do all transplants in the future, whether it's other organs, adults or kids, even if we decided to apply this technology down the road to xenotransplantation, which has been new in the media recently with the pig heart transplant and the pig kidney transplant. But this is a complementary type of discovery here that would work hand in hand with xenotransplantation as well. So it really has broad implications, and this is truly a historic case.
Thank you so much, Dr. Turek. And Kaitlyn and Brandon, if there was one message that you could encapsulate time capsule style for Easton to know in the future, for him to have, for everyone to see in the public, what would that one message be?
I think my biggest thing is, especially with all the scars that he has, is just to be proud of those and know that we did everything for what was the best decision for at that moment, and that he should be proud of those, because it's something that he was fighting for his life, and he should be honored to let people know that that's one thing that he did and that he got to make a difference.
Mm-hmm.
Absolutely. A world of difference. The first in the world to receive a combination heart transplant and process thymus tissue. Amazing. Of course, thank you all so much for joining us. Thank you to our panelists, Dr. Joseph Turek, Kaitlyn Sinnamon, and Brandon Sinnamon, and for a time there, Easton Sinnamon himself for sharing their experience. We're going to have a recording of this briefing available for you on the Duke University YouTube page. And if you'd like to be notified of upcoming briefings, please email dukenews@duke.edu. We do have an upcoming briefing on Wednesday, this next Wednesday at 9:30 a.m., where we're going to be discussing long COVID with 2 Duke pulmonologists. In the meantime, please be well. Thank you so much. Have an excellent day.